Welcome to the deep dive. Today we're taking a stack of clinical sources, really aiming for a rapid but comprehensive look into substance use disorder, or SUD. We're focusing on the pharmacology side, how these drugs actually work, and crucially, the nursing process needed to keep patients safe.
And the scale of this is, well, it's huge. Sources mention nearly 165 million Americans aged 12 plus were substance users in just the past month, back in 2018. And the key thing, the mindset shift we need is seeing SUD as a chronic disorder.
Right, so relapse isn't some kind of personal failure.
Exactly. It's an expected part of the illness, really.
Hmm.
It tells us treatment needs adjusting, not that the person has failed.
Okay, so before we jump into specific drugs, maybe clarify some terms like physical versus psychological dependence.
Good idea. Physical dependence is physiological, the body's adapted. You get tolerance, meaning you need more for the same effect, and definite withdrawal symptoms if the substance is stopped.
And psychological.
That's the intense craving, that overwhelming desire to get and use the substance, even knowing the harm it causes. It's a compulsion.
And you also mentioned habituation.
Yeah, habituation's a bit different. You might see it, say, after surgery with prolonged opioid use. There's tolerance, maybe some mild psychological reliance, but not usually the major withdrawal or the compulsive drug-seeking behavior you see in addiction. Still needs careful management, though.
Okay, that framework helps. So our mission today, unpack the big five classes: opioids, stimulants, depressants, alcohol, and nicotine. We'll look at how they work, the effects of withdrawal signs, and the treatment and nursing care. All right, let's start with opioids.
Okay, opioids. Think heroin, codeine, oxycodone, and increasingly fentanyl. These are often linked to the highest risk of death. That intense euphoria, the rush, happens because they bind directly to opiate receptors. This causes analgesia, drowsiness, and a state called narcosis, basically a stupor.
And this is where we see things like fentanyl lacing becoming so deadly, right? What about that combination sometimes called the Holy Trinity?
Ah, yes. The Holy Trinity is incredibly dangerous because of synergy. It's typically an opioid plus a benzodiazepine and often the muscle-relaxing carisoprodol or soma.
So they all depress the system.
Precisely. Each one depresses the central nervous system. Put them together, and the risk of respiratory arrest just multiplies. It's far greater than any one drug alone. That combined CNS depression is the killer.
Okay, so respiratory depression is the main cause of death. What else are nurses looking for besides breathing?
Well, opioids also trigger histamine release. That can cause vasodilation, leading to low blood pressure, hypotension, and they really mess with GI and urinary function. Severe constipation and urinary retention are common.
And withdrawal, what does that look like?
It's basically the body rebounding hard. Instead of pinpoint pupils, you get dilation mydriasis, sweating, or diaphoresis, runny nose, rhinorrhea, and those classic goosebumps, piloerection. Plus, blood pressure and pulse shoot up.
When does it hit hardest?
Usually peaks around 1 to 3 days after stopping, and the whole acute phase lasts maybe 5 to 7 days. It feels like a very, very bad flu, but worse.
So if someone's overdosing right now, what's the immediate fix?
That's naloxone, the opioid antagonist. It kicks the opioid off the receptors fast. First responders carry it, thankfully.
And for managing the withdrawal itself, not the overdose.
For withdrawal, we often use methadone substitution. It's a long-acting opioid, so you can taper the dose down slowly, making it smoother. Or we use clonidine.
Clonidine, isn't that usually for blood pressure?
It is. That's exactly why it works here. Opioid withdrawal is like a massive sympathetic nervous system storm, high BP, high pulse, anxiety. Clonidine is an alpha-2 agonist. It dampens that sympathetic overdrive.
Ah, okay.
And this is critical for nursing because it lowers blood pressure. You absolutely must check the patient's BP before giving it.
Got it. Critical safety point.
Good.
What about preventing relapse long term?
For that, we have naltrexone. It blocks the opioid receptors, so if the person uses, they don't get the euphoria. But another huge safety point. The patient must be opioid-free for at least a week, maybe 10 days, before starting naltrexone. Otherwise, you'll trigger immediate, really severe withdrawal.
Okay, so that's the downers, the depressants that slow everything. Let's switch gears completely. Stimulants, the ones that speed everything up.
Right. Amphetamine, methamphetamine, including crystal meth or ice and cocaine or crack. These are all about that intense alertness, elevated mood, feeling powerful.
What's happening chemically to cause that?
They work mainly by forcing the release of norepinephrine from nerve terminals. It's like opening the floodgates. This norepinephrine surge jacks up the CNS, wakefulness, euphoria, and also slams the cardiovascular system. Think high blood pressure, racing heart, dangerous irregular heartbeats, or dysrhythmias.
I think the sources mentioned a kind of weird side effect, something with the bladder.
Oh yeah, it's an odd one. Stimulants cause the urinary bladder sphincter to contract. Therapeutically, that's sometimes used for bedwetting and uresis. But for users, it can mean difficulty or pain when urinating micturition.
And what about MDMA, ecstasy, or Molly? Is that just another amphetamine?
It's a synthetic derivative, yeah. Popular at raves, sometimes called a love drug, but it has a unique, really dangerous risk. Severe hyperthermia. It can make body temperature skyrocket, leading to organ failure very quickly.
Wow. Okay, so with all that energy surging, what happens when someone stops the crash?
It's the complete opposite. Total depletion, profound social withdrawal, feeling like you could barely move, psychomotor retardation, sleeping excessively, hypersomnia, eating excessively, hyperphagia, deep depression, and a very real risk of suicidal thoughts.
Is there an antidote for stimulant overdose?
Unfortunately, no specific pharmacologic antidote. Acute toxicity treatment is supportive, often requires sedation. Death, when it happens, is usually from convulsions, coma, or stroke cerebral hemorrhage.
All right, let's move to the next category, depressants. This includes things like benzodiazepines and barbiturates, which have legit medical uses, but also marijuana.
Yeah, benzos and barbiturates are used for anxiety, seizures, sleep. Marijuana is actually the most commonly abused illicit drug globally. The common thread here is GABA. These drugs enhance the action of GABA, which is the brain's main inhibitory neurotransmitter. So they calm things down, relieve anxiety, cause sedation, relax muscles.
We definitely need to talk about the date rape drugs here. That's critical.
Absolutely essential. Flutitrazepam, brand name Rohypnol, often called roofies. It's a benzodiazepine. It causes disinhibition, sedation, but the truly insidious part is the amnesia. Victims often can't recall what happened. And then there's GHB, gamma hydroxybutyrate, sometimes called liquid ecstasy, though it's a depressant. It's profoundly sedating. And the danger skyrockets because these are often given to someone who's already had alcohol. The combined effect could easily lead to coma and respiratory arrest.
Really scary stuff. Okay, shifting to marijuana, what are the active parts people should know?
The main psychoactive component is THC, delta-9 trans-tetrahydrocannabinol. That's what causes the high. It hits cannabinoid receptors, leading to mild euphoria, sometimes memory lapses, increased appetite, faster heart rate. The other ingredient you hear about is CBD, cannabidiol. Importantly, CBD does not cause a high.
Okay. Benzos are used medically, but withdrawal sounds risky too.
Extremely risky if stopped abruptly, especially after long-term or high-dose use. You can get seizures, delirium, really bad rebound anxiety. It can be life-threatening.
So how do you manage that withdrawal safely?
You never stop them abruptly. The standard is a slow taper, often using a long-acting benzo like diazepam over maybe 7 to 10 days, sometimes longer. And if someone presents with an acute overdose of benzodiazepines, there's an antidote for that, flumazenil. It competes with the benzo for the receptor sites in the brain, effectively reversing the sedation.
Okay, next up, alcohol. Ethanol, ETOH. Culturally, it's everywhere, but the damage can be immense. Let's talk chronic effects first. Neurologically?
Long-term heavy use is devastating, often linked to severe B vitamin deficiencies. This leads to serious conditions like Wernicke's encephalopathy and Korsakoff's psychosis. Korsakoff's is particularly striking. It involves significant amnesia, but also confabulation. That's where the person unknowingly creates false memories to fill in the gaps. It's not lying. Their brain is trying to make sense of things.
And it's not just the brain, right?
Not at all. You see irreversible heart damage, cardiomyopathy, and liver damage leading to cirrhosis. It really hits multiple organ systems hard.
And the patient safety note regarding pregnancy cannot be stressed enough.
Absolutely critical. Ethanol is a powerful teratogen. It interferes with cell growth very early in pregnancy, causing fetal alcohol syndrome, a range of lifelong physical, mental, and behavioral problems. There's no known safe amount of alcohol during pregnancy.
When someone physically dependent stops drinking, withdrawal can be incredibly severe. Can you describe that spectrum, especially delirium tremens?
Right. Mild withdrawal might just be elevated vitals, BP maybe over a 50-90, pulse over 110, some tremors, feeling agitated. But it can escalate quickly to severe withdrawal or delirium tremens, the DTs. That's a true medical emergency. We're talking BP over 2,140, pulse racing above 140, temperature spiking over 101 degrees AF, severe confusion, hallucinations. DTs can be fatal.
So if someone is in DTs, what's the treatment?
Benzodiazepines are the absolute standard of care. For severe DTs, they're often given intravenously, usually in an ICU setting, to sedate the patient safely and prevent complications like seizures.
What about helping people stay sober long term? I know about disulfiram or antabuse.
Disulfiram is an older option, really only for highly motivated people, because if you drink any alcohol while on it, you get violently ill with the acetaldehyde syndrome. Intense flushing, nausea, copious vomiting, dangerous drop in blood pressure, with strong negative reinforcement. A newer medication is a camprosate, helps maintain abstinence, possibly by stabilizing some neurotransmitter systems disrupted by chronic drinking. The exact mechanism isn't fully clear, but it helps reduce cravings for some people.
Okay, last category, nicotine. A legal, widely available stimulant, but definitely toxic and highly addictive. You mentioned paradox.
Yeah, it's interesting. People often say they smoke to calm their nerves, but pharmacologically, nicotine triggers the release of epinephrine adrenaline. That causes physiological stress, not calm.
So how does it work? What's the mechanism?
Nicotine directly stimulates specific receptors, nicotinic receptors in the autonomic nervous system, adrenal glands, skeletal muscle, and the brain. It causes a quick burst of CNS stimulation followed by depression. That up and down cycle is part of what makes it so addictive.
And the physical effects.
Cardiovascularly, it increases heart rate and blood pressure. In the GI tract, it can increase bowel activity, cause nausea, vomiting. High doses are toxic, and death, though rare now from just smoking, would typically be from respiratory failure.
For people trying to quit, nicotine replacement therapy, NRT, is common. Gum, patches, sprays.
Right. The patch is interesting because it often uses a stepwise reduction system. You start with a higher dose patch and gradually decrease the dose over weeks, weaning the body off nicotine slowly.
Are there non-nicotine medications too?
Yes. Bupropion, which is also an antidepressant, was the first prescription medication approved that didn't contain nicotine. And currently, a major player is varenicline, brand name Chantix.
How does varenicline work?
It's quite clever. It's a partial agonist. It partially activates the nicotinic receptors, which helps ease withdrawal symptoms, but it also blocks nicotine from binding effectively if the person does smoke, reducing the pleasure or reward from smoking.
Now, I recall there were some significant safety warnings about varenicline a while back, psychiatric side effects.
You're right, there were. The FDA issued warnings about potential links to agitation, depression, even suicidal thoughts. However, and this is an important update, larger, more recent studies haven't actually shown a significant difference in the risk of these serious psychiatric events between varenicline and placebo. So the concern level has decreased based on newer evidence.
That's really good to know. Okay, we've covered a ton of pharmacology. Let's bring this back to the nurse's role. Given how common SUD is, nurses are often on the front lines, right? The sources mentioned something really important first, addressing our own biases.
Absolute fundamental. Addiction carries so much stigma. As nurses, we have to examine our own beliefs and attitudes to make sure we're providing compassionate, non-judgmental care. If a patient senses judgment, they won't be honest about their substance use, and we can't keep them safe without that information.
So assessment starts there. What about tools?
Screening tools are key. One of the simplest and most effective is the CAGE questionnaire, just 4 quick questions.
CAGE, TAGE. Let's see, cut down. Felt the need to cut down.
Yep. Annoyed. Been annoyed by people criticizing your drinking or drug use.
Guilty, felt guilty about it.
And eye-opener. Ever needed a drink or drug first thing in the morning to steady your nerves or get going? 2 or more yes answers suggest a potential problem. There's also CAGE Aid, adapted for drug use too. It's remarkably accurate for such a quick screen.
Okay, so once a problem is identified, or if someone presents in withdrawal or overdose, safety is number 1.
Paramount, always. Think ABC's airway, breathing, circulation, especially with opioid or CNS depressant overdose or severe alcohol withdrawal. That's the immediate priority.
And if things escalate to, say, DTs with hallucinations?
Safety, safety, safety. Implement seizure precautions. Try to maintain a calm, quiet environment. Use restraints only as a last resort if the patient is a danger to themselves or others, and follow protocol strictly. Non-judgmental reassurance is still key, even then.
Briefly, any specific considerations for different age groups?
Yes. With older adults, substance abuse can be hidden. They might be isolated, have multiple health problems, take many medications. The risk of dangerous drug-alcohol interactions falls. Confusion is really high. For adolescents, alcohol is still the most frequently abused substance. Prevention and education have to start early. We need to reach them before patterns get entrenched.
Okay, let's try to quickly pull this all together. We've hit the major categories.
Right. Opioids. Euphoria, but high risk of respiratory failure. Stimulants, that norepinephrine surge, but risk hyperthermia, cardiovascular issues. Depressants, working on GABA, but dangers of amnesia, lethal combos with alcohol. Ethanol, chronic organ damage, potentially deadly withdrawal. And nicotine, that paradoxical stimulant causing dependence via CNS ups and downs.
Understanding those different pathways is so vital for treatment, isn't it?
Absolutely, because the immediate treatment for an overdose is totally different for opioids versus, say, benzos. And monitoring during withdrawal requires knowing what to expect, often the opposite effects of the drug itself.
We've talked a lot about managing the acute crisis, but SUD is chronic. Relapse happens. So thinking bigger picture, how can we health providers, the system, better connect that acute care with long-term support? How do we use resources, maybe like SAM-HITS or just better patient education, to really bridge that gap and support sustained recovery after someone leaves the hospital? That's maybe the thought to leave you with today.